Hi, I'm Elsa Faure. I'm vascular surgeon in University Hospital of Nîmes, France, and I am pleased to share with you the result of our study on the use of cold store saphenous vein allograft for vascular access. Successive access creation over time can lead to an exhaustion of the venous capital and the limitation of new access creation, seat and conduits. Many vascular graft material have been used over the past decade for hemodialysis access, including in particular ePTFE, prosthetic graft, which are widely used due to their availability, the short time before cannulation, and their low cost. However, they are associated with a high rate of occlusion, seromas, post-anastomotic stenosis, and infection, and their implantation in a septic area should be avoided. Cold store saphenous vein allograft stored at 4 degrees have been used as an alternative to prosthetic graft since the 90s to avoid this complication. However, there is only data in the literature reporting their long-term outcome. Cold store saphenous vein allograft used in this study were obtained from Biopotec, a human tissue bank which collects, conditions, and distributes cold store saphenous vein allograft. The saphenous vein is collected from voluntary donors during varicose vein stripping or during multi-organ retrieval. The grafts are then stored at 4 degrees in a saline solution containing antibiotics for minimum 3 weeks. The diameters of the conduit must be between 3 and 10 millimeters. When we use it electively, we order to the manufacturer the longer and the diameter we need for the procedure minimum 2 days before. And for emergency cases, we have some cold store venous allograft in deposit stored at 4 degrees in a refrigerator. The procedure is the standard bypass vascular access procedure with antibiotics and heparin. And first access cannulation of the graft can be performed 3 weeks after the implantation. So in this two-center retrospective study of 109 patients, we reported a secondary patency rate at 1 year of 73.3% and of 54.9% at 2 years. When we are regarding the cumulative incidence of adverse event by the fine and gray method, considering competing risk like death and renal transplantation, only 9.2% of the patients lost their vascular access at 1 year and 18 patients at 2 years. Infection of the cold store saphenous vein was reported only in 5 patients. Kaplan-Meier estimate of freedom from infection at 1 and 2 years were respectively 97.1% and 95.7%. So in our study, patency rate of cold store venous allograft were comparable to those reported in the literature with prosthetic graft, but cold store venous allograft were associated with a lower rate of infection, nearly half of the incidence reported with prosthetic graft in the literature. Also, while infection of ePTFE often required a complete removal of the graft, infection on cold store venous allograft seem to remain localized and could be treated by limited interposition of a new cold store venous allograft segment that ensures the continuity of the hemodialysis on the vascular access and avoids the implantation of a central venous catheter for the patient. Another point important to discuss is that the endothelium of the cold store venous allograft disappear during the 3 weeks of storage in the saline solution before it is placed, which makes it theoretically non-immunogenic compared to cryopreserved graft. We recently published a study evaluating the immunological response following cold store venous allograft. And we demonstrate that they do not induce any HLA reactivity, alloreactivity. So this cold store venous allograft can be safely used without risk of HLA alloimmunization, especially for the creation of vascular access, which is crucial for this patient potentially awaiting for renal transplantation. For this reason, we suggest the use of cold store venous allograft when the venous capital is exhausted, especially in patients with reported risk factors for vascular infection, like insertion in the tight, advanced age, diabetics, immunocompromised states, or obesity, or for the revision of an infected prosthetic graft. And in our practice, we use the cold store saphenous vein preferably over prosthesis when autogenous options in both arms have been exhausted. Thank you. Thank you for your attention.